Um, I want to thank everybody for being here tonight. This is a topic that is sometimes not easy to talk about, but it's definitely something that should be brought up with your family as a conversation, and then obviously with your epileptologist, your neurologist at the same time. So we're really happy to have Dr. Culler here from Dartmouth talking about I am going to pull up I have your information, Dr. Culler. It is okay if I talk a little bit about you
Sure.
um,
Yeah.
and about your background? So Dr. Culler is an epileptologist at Dartmouth Hitchcock Medical Center. He's also an assistant professor at Geisel School of Medicine in Dartmouth. He also went to medical school at the Baylor College of Medicine in Houston, Texas. He did his internship at Baylor College of Medicine in Houston and followed up with his residency prior to that at Northwestern University Feinberg School of Medicine in Chicago. His areas of interest are epilepsy, epilepsy surgery, and intraoperative neuromonitoring. So we're really excited to have him here with us. A little house cleaning tips. If you have questions to ask, please place them in the chat. We're happy to get those questions to Dr. Culler. The other piece that I also want to tell, if you are here today as a school nurse and you need this as a contact hour, please let us know in the chat with your email address and saying that you're a school nurse. So that way we can make sure to get you that contact hour. So other than that, I'm going to pass the mic to you, Dr. Culler. So happy to have you.
Yeah. Really appreciate it, Christine. Thank you. And on behalf of New England chapter of the Epilepsy Foundation for inviting me to talk about this very serious topic. And then thank you for attending. Please don't hesitate to ask questions or you can save them for the end. Yeah. So I'm going to try to just kind of present the raw kind of facts and data that we have. At times, it's just I'm kind of just describing the tip of the iceberg. There's a lot of interesting studies and research that are ongoing. There's so many questions that we know a little bit more about, but we still don't completely understand what causes SUDEP, sudden unexpected death in epilepsy. So here we go. I have no relevant disclosures. I don't, get money or anything like that from any companies. So, and I have avoided the use of naming any kind of devices or drugs or anything like that in this talk. So these are the highlights of the points I'd like to discuss tonight. This will include defining what sudden unexpected death in epilepsy is, and also briefly touch upon what are the other causes of mortality in patients with epilepsy. We'll review the incidence rates of SUDEP, kind of explain a little bit, this is probably the densest part, just proposed mechanisms of what might, pathophysiologic mechanisms of what underlies SUDEP. And then identify the risk factors. I think the second half of the talk will likely be a little bit more relevant and what immediately patients and their families are more interested in, like, am I that person who might be higher risk for something like SUDEP? And what can I do to try to reduce that risk? And finally, this is more for the clinicians. I've given this talk to clinicians as well, but just so it should really be the review of importance of open communication between the medical team and patients and families about SUDEP. So just like I try to push my colleagues to talk about this topic, you in turn though should also push your physicians to talk about this topic. Once again, what is the definition? So this is a sudden, unexpected, witnessed or unwitnessed, non-traumatic, non-drowning death in someone with epilepsy who is otherwise healthy. So it's a death that unfortunately occurs, but there's not a competing cause for it. It typically occurs after a convulsive seizure. So a big, the older term is grand mal seizure or tonic-clonic seizure. However, there have been cases reported of SUDEP occurring after a focal seizure, one without the tonic-clonic component. And there are even very rare cases where someone is found dead and there wasn't thought to be a seizure before that, and there wasn't another definite cause. To have the definite diagnosis, an autopsy should have been performed to rule out any other medical causes. And just a little bit along that line, why it's sometimes hard to perform research is because a lot of times there is some doubt or competing cause for why someone might have died. Can imagine if someone has epilepsy in their 70s or 80s, they might also have other medical issues like cardiovascular issues, or maybe they have a history of clotting disorder. There can be other reasons for a sudden death. And so definitions like probable SUDEP is essentially the same as definite SUDEP, but without an autopsy to confirm. Possible SUDEP usually means somebody has other medical issues as well. A near SUDEP is a patient with epilepsy that does survive, has a cardiorespiratory arrest, so their heart or their breathing stops, and then they are able to be resuscitated. And then, of course, it's important if there's another definite reason why someone might have died, it is not SUDEP. So SUDEP is the leading cause of epilepsy-related mortality. Depending on the study, it's up to 20% of all deaths. This is a serious and underappreciated public health problem. And it's a very sensitive type of discussion. It's very hard to bring up in a clinic visit, especially when you're just meeting somebody. And so I think, just using this time to give you the evidence-based information is a nice time for learning outside of those therapeutic relationships. So while it's uncommon, it's likely the most common cause of death in people with epilepsy. And each year it's around 1 in 1,000 people with epilepsy who will die from SUDEP. Now, what are the other causes of mortality in patients with epilepsy? Well, many haven't heard of things like status epilepticus. That essentially means you have a seizure that lasts. It's a prolonged seizure lasting over 5 minutes. And the longer a seizure goes, this is very uncommon, but some people do have this. It's harder for that seizure to stop on its own. Then, of course, if you have a seizure when you're sort of in an unsafe environment, or unfortunately, if you're driving or you're swimming, then that opens you up to drowning or a car accident. Sometimes patients can have aspiration pneumonia if they kind of choke on saliva or eating. Certainly, there can be a heart issue after a very severe seizure. It's very important to note that patients with epilepsy actually have independently higher incidences of anxiety and depression. And just briefly touching on this is also a very important issue, and it's because seizures often take away your independence, and medications affect how you think, and it can be tough if you can't drive anymore. And so suicidality can be high in patients with epilepsy. It's a very important issue. And then finally, the reason you have seizures, if it's related to a brain tumor or some type of metabolic disorder or some other medical issue, that those type of medical issues might progress and be quite serious. I throw this in here for a couple of reasons. It's actually a little bit misleading. So this indicates the peak incidence, looking at, I think there are a couple of tens of thousands of people. The peak incidence of SUDEP appears to be around age 30 or 20 to the 40s. And this indicates that the years of potential life lost within all neurologic diseases is second only to stroke. So it's it's really important entity to understand and try to prevent. It seems that it's relatively unusual in patients that are older, like above 45 years old or 50s or 60s. But the caveat is that, like I had alluded to earlier, there's often competing medical issues, and clinicians, doctors don't feel as comfortable maybe making that diagnosis of SUDEP, which is death in a otherwise healthy patient with epilepsy. So we should dive a little deeper in this incidence number, the 1 in 1,000. So the estimates really vary widely depending on the population considered. And so these numbers, the first 3 lines, are based off of a 2017 systematic review by the American Academy of Neurology that looked at 12 kind of well-designed studies on the incidence of SUDEP. So it appears that that risk is lower in children, around 0.2 per 1,000 patient years. I'll go into that a little bit more. And then the risk in adults is higher at 1.2 per 1,000 years. And there was another nice meta-analysis done by this group published in Epilepsy, kind of showing a range very similarly, 0.3 to 1.3 per 1,000 patient years. So those numbers likely don't mean anything to you unless you most recently took a biostat course or something like that. So we can break it down and compare it to something that maybe more of you have heard of. So the epilepsy prevalence in the US population is around 1.2%. That does come out to be a lot of people. And if we take that incidence of 0.3 to 1.3 thousand patient years, it comes out to about 1,300 to 5,000 cases of reported SUDEP per year. So something that's very similar that we don't really understand the phenomenon is something called sudden infant death syndrome, or SIDS. And this is something, if you were, currently a parent to a newborn or recently had a newborn, something that you've heard about and really worried about and probably talked to your pediatrician about. And, the most recent figures from a study in 2020 say there's about 1,380 cases in the US. So despite SUDEP being at least as common as SIDS, nearly everyone has heard of SIDS, and certainly new parents are highly aware, but SUDEP kind of remains relatively unknown to those that are surveyed, including those in the medical care provider, medical society. One other thing I would say, going back to these numbers, so another way to think about it, so 0.2 per 1,000 patient years. So that's, if you were to have 1,000 patients with epilepsy over the next year, 0.2 would have SUDEP. That's very hard to conceptualize. So you can turn that around and say it's 1 in 4,500 children with epilepsy will have SUDEP, and then in adults it's around 1 in 1,000. All right, kind of shifting our focus a little bit. So what are the potential mechanisms? Like, what's happening in the body after a seizure or during a seizure that might cause this? So, because most of these cases are actually unwitnessed, the exact sequence of events is not known for a majority of cases. But what we do know, it's almost always after a generalized tonic-clonic seizure, also known as a grand mal seizure. And it's widely believed that it's an interplay of respiratory dysfunction after a seizure, or cardiac arrhythmia, or brain dysfunction. There may be an underlying genetic risk factor that still, needs to be studied more, and all of these together may lead to SUDEP. If you asked a group of neurologists maybe 20 years ago what they thought was the primary cause, it was it was typically going to be a primary heart issue. What we knew at that time, 20 years ago, is that most seizures induced what we call a tachycardia, or elevated heart rate. And in rare cases, the heart actually kind of stopped momentarily or had a really low heart rate with seizures. But the prevailing kind of thought process, based off some of the data has come out in the past 15 to 20 years, has switched more to that there's likely seizure or post-seizure induced respiratory dysfunction that then leads to the cardiac dysfunction. So this opinion really changed after this kind of aptly named Mortimer study, which stands for Mortality in Epilepsy Monitoring Unit study. So not every patient visits an epilepsy monitoring unit, but this is a place in the hospital where it's a safe spot with well-trained nurses and physicians, where we record people's brain waves and try to record their seizures to make the diagnosis of epilepsy. And unfortunately, over the course of decades, with these EMUs all across the world, just volunteering the information to this study group of, because that's a lot of seizures that were recorded. Did any of these places have a monitored SUDEP? It's kind of a scary thing to think about, but it does turn out that there were a few cases like that. And when these cases were, and I'm simplifying this graph here, when these cases were analyzed by examiners, what they saw was that the patients who did have, who did die from a seizure, and these were all generalized tonic-clonic seizures, that in blue they had a terminal apnea. What that means is they stopped breathing, and then in red they had an asystole, which is the heart stopped beating. So it basically showed that there's severe respiratory dysfunction after a seizure that leads to the heart not being able to beat anymore. This is a nice figure that might be a little bit easier just to kind of conceptualize what happens during a seizure, which is in pink. This is very common, especially in a generalized tonic-clonic seizure. You see that at the baseline, the blue line, the oxygen saturation on the y-axis is 100%. And as the seizure goes on in pink, and right before it ends, you get to the lowest point in the oxygen saturation curve. And this patient's O2 sat went down to about 40%. Most people start to feel really uncomfortable if you're holding your breath and you get down to 90%. And then you see the slow improvement after the seizure. I bring this up too, also to show clinicians that this, in fact, wasn't a grand mal seizure. It was just a focal seizure. It was a patient who became confused, was just sitting in bed in a monitored setting, and the seizure lasted, looks like just over 2 minutes. Am I supposed to admit? Oh, maybe someone's already done that. So yeah, the respiratory dysfunction can be quite profound, even in a focal seizure, one that doesn't progress to a big grand mal seizure. So this is basically a summary of clinical data that we know. So we call this a central apnea when patient has a seizure and they stop breathing during that time. And it's actually very common. And we only started to know about this in the last 10 to 15 years, because we started routinely measuring respiratory breathing rates with respiratory belts. And we only some centers actually do this routinely, but the ones I practice and do this. And we know that it's likely associated with temporal lobe epilepsy and seizure spread to the amygdala, which is a very important structure in the temporal lobe. And then finally, there have always been some thoughts, when you have a tonic-clonic seizure, and if you've ever witnessed a big seizure, and sometimes there are these guttural sounds, or like someone's choking, could it be an obstructive phenomenon? But in studies looking at all these seizures in a monitored setting, it's unlikely to be related to this, because with the respiratory belts and nasal breathing thermistors, it's like a sleep study. We're able to actually distinguish between essential apnea and an obstructive apnea. So I'll probably skip over this. This is essentially kind of showing the same thing in a severe type of epilepsy called Dravet syndrome, that patients will stop breathing at during and after their seizure, and continue to have uh, disordered breathing. Let me just have a pointer here. That, like, hypoventilation, like smaller respirations than their pre-baseline here. And this can last for hours after a seizure. So I'm kind of building up to the potential mechanism of SUDEP. Once again, we have EEG, or brain waves. This is the end of a seizure. We have nice breathing waveforms, but after the seizure, the 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 the, the chest and the abdomen breathing belts are flat. And so this is an example of a post-convulsive central apnea. So just more examples of how breathing is disordered during a seizure. This is not as common as the in seizure breathing abnormalities, but it's still there in about 20-30% of patients. It can happen in generalized and focal epilepsies. And finally, this group from Iowa has really been spearheading this study of how the body responds to increased carbon dioxide, which is actually a waste product. When you don't breathe regularly, you build up carbon dioxide, and the body's response is to start to hyperventilate. And what they noticed in patients potentially at risk for SUDEP is that they don't have a normal response to having more CO2. And this kind of shows that there are patients out there that might be at risk uh, after having a big seizure, that they're not going to mount that a typical arousal response to having a seizure, like waking up and to actively start breathing again. Finally, one last, just this is an area of study when I was in fellowship. I just wanted to show these very nice breathing responses, like one every 2 to 3 seconds, a big breath. And then the seizure begins on the EEG. It's impossible to really take a look at it because I've scrunched it up so much, and the breathing just flattens. And this goes on for 20-30 seconds before anybody knows the patient's having a seizure. So I'm going to summarize that. Now, I know that was a lot, but essentially there's a big case that respiratory dysfunction drives the sudden unexplained or unexpected death in epilepsy. So this began with that Mortimer study that I showed, but then has been seen in animal models and patients who have kind of severe epilepsy, that it seems like it's always breathing abnormality and then a heart issue. So naturally, because the prevailing thought is that it's more respiratory, the kind of the camp that believes it's a primary cardiac issue, we don't have as robust data. But these are the potential causes, because seizures can induce all these abnormalities in somebody, and we've recorded that, and we routinely record EKG, or heart rate, when someone's being monitored in our center. So it can often cause fast heart rates, slow heart rates. Atrial fibrillation is very rare. It may cause something called prolonged QT. The seizure itself, it can, if you've ever seen one, and there's so much activity motor activity, it can cause this catecholamine surge, autonomic dysfunction, and heart rate variability. And I bring that up just because that can be associated with cardiac dysfunction. Just briefly, the ictal means in seizure, bradycardia or slow heart rate, and asystole or no heart rate. Very rare, very rarely seen with seizures, but not associated with SUDEP. And so these rates are under 2% of seizures, typically associated with temporal lobe seizures. And then finally, we're in an era where genetics is becoming the hot new thing to work up epilepsy, because a lot of patients' epilepsies we don't know why they began or why they start. We know that there are structural lesions in the brain, lesions that some people are born with or they acquire later in life, but that's still somewhat of a minority of patients that have epilepsies. A lot of people just have normal MRIs of the brain. And why are genes and genetics possibly key to figuring out who is susceptible to SUDEP? Well, it's because there are a lot of genes that are expressed in both the brain and the heart. So you would think if you have an abnormality in that gene, then you can have dysfunction in the heart and the brain. And that's a perfect setup for a seizure and then the heart stopping. So, and probably the biggest study we have so far of 61 SUDEP cases, 15% had variants in one of 32 known cardiac rhythm-related genes. As some called the KCNH2 gene associated with long QT syndrome, which is associated with cardiac arrhythmias, sudden death, and seizures. So, but this doesn't prove causation. And just because you have a variant in a gene doesn't mean that you necessarily had abnormalities or that's what happened. And I have to remind everybody that most cases of SUDEP is unwitnessed. So. Otherwise, so far, no SUDEP cases have been associated with genes associated with central breathing abnormalities. Once again, I think the animal data is really showing that it's a respiratory issue, then a heart issue, and then also confirming that patients after seizures just have are not able to wake up as well. They aren't responding to that high level of CO2. So to kind of finally summarize that, we're still in this model where it seems that cardiac and respiratory abnormalities both occur quite commonly, but I think a lot the driving factor might be the respiratory dysfunction. And then finally, that can genetic risk factors be playing a role? We don't quite know yet. So the last kind of 10, 15 minutes here, I think, hopefully you're still with me here, I think will be a bit more relevant. I think it's data that we can jot down and really understand, because the reality is, despite all the studies we have, there are only a couple of risk factors that come that have been identified consistently across all of the literature as increasing the risk of tonic-clonic seizures, or sorry, the risk of sudden unexpected death in epilepsy. So that is in bold here: presence and frequency of generalized tonic-clonic seizures. So if you have more of these, then you're at higher risk. And so, for example, 10 times higher risk compared to those without generalized tonic-clonic seizures, 15 times higher risk when having 3 or more per year as compared to less than 3 tonic-clonic seizures per year, and then 27 times higher if you've had a tonic-clonic seizure in the past year versus no tonic-clonic seizures. So that last statistic was from a newer study. The first two was from the meta-analysis performed by the American Academy of Neurology in 2017. So these numbers differ a little bit depending on what source you read from, but essentially they're all saying the same thing. Finally, if you live or sleep alone and have tonic-clonic seizures, you're at higher risk of having SUDEP. And then consistently also in patients who admit or have missed medications or frequently forget medications, this typically is associated with having more breakthrough seizures and then increasing your risk. So that will become very important that you do not miss your medications if that's one of the triggers for seizures. So a lot of what's on this slide was summarized by the American Academy of Neurology. I would point your attention to the last couple of rows, which is slightly new information, that they found that there was a risk reduction if a patient had some form of nocturnal supervision. So what exactly does that mean? That can be anything from living in a household with somebody, and if you're living with someone in a household, are you sharing a bedroom with them or not? And this was further studied in that 2020 nationwide cohort in Sweden. It's a very nice study that the patients who had a bed partner had probably the best odds of lowering their risk of SUDEP. And then also this use of nocturnal listening device was a risk reduction. That was a way to notify if there were some loud noises or something that could detect a lot of movement, that was a potential way to notify somebody was having a seizure. In that same study, there were many factors that may portend a slight increased risk or an increased risk in the context of low or poor evidence. So I bring this up, but just to highlight that this may be associated with an increased risk of SUDEP, but we really don't know. So you have to take it with kind of a grain of salt. So having just primarily nighttime seizures, LTG means lamotrigine use in women. I think that which is typically a very good medication, and then not being on any anti-seizure medication. You'll hear quoted a lot the male sex or gender too, and then also being on sedative medications, the anxiolytic drug use. So, but once again, it's kind of poor evidence. I do want to bring some attention to so the face down sleep position, or really it's being found face down at the time of SUDEP. It seems that sleeping face down or being found face down was more common in patients with SUDEP. I bring that up. It's more of it kind of makes sense because you're not adequately ventilating well. But there's not so much we can do to prevent that. I think there are pillows out there that aren't they're supposed to allow more adequate air exchange, but I think it's just an interesting point to bring up. Finally, I do want to bring up a little bit about epilepsy surgery. And to segue into that, we only consider epilepsy surgery in patients who have something called drug-resistant epilepsy, or medically intractable epilepsy. What exactly does that mean? It means you've tried, the classic definition is you've tried 2 anti-seizure medications and continue to have seizures. So in general, 60 to 70% of patients become well controlled on anti-seizure medications with one or two medications. But there continues to be about a third of patients with epilepsy who continue to have seizures despite choosing different anti-seizure medications, and we don't exactly know why. But it turns out that their rates of SUDEP are higher, so closer to the 6 to 9 per 1,000 person years, as compared to 1 per 1,000 person years that I first started this talk with. So that segues into, why we, not just for seizure freedom and improved quality of life, but why do we pursue resective or epilepsy surgery in patients with drug-resistant epilepsy? And there actually have been studies looking at the rates of SUDEP, and it shows that, including all-cause mortality and SUDEP, that patients who received an operation had lower risk of SUDEP. If someone went through surgery and still had persistent tonic-clonic seizures or generalized tonic-clonic seizures, that was a stronger predictor of SUDEP. And if you're not a candidate for a resective surgery, there are options for neurostimulation that do improve seizure control, and that's also been shown to reduce the odds of SUDEP. So how can we prevent SUDEP? Really, if we focused on the risk factors that are consistently, what's associated with increased risk, which is the tonic-clonic seizures, then it's really optimizing seizure control. And one of the most common reasons people come to the ER with breakthrough seizures is because of, I forgot to take my medication or not taking medication consistently. It can be really hard, especially if your epilepsy has left you with poor memory, or just you're not an organized person to begin with. So medication adherence is really important, and what I try to really establish with my patients, whether that's having someone to remind them, setting alarms, having a pill box, having regular follow-ups, working with an epilepsy specialist if you're one of those patients with drug-resistant epilepsy, and then considering surgical options. And an epilepsy specialist too can also talk about non-pharmacologic therapies and also the newest medications out there. Then finally, lifestyle modifications. So sleep is so key. Making sure you protect your sleep, avoiding triggers if you have a specific type of epilepsy that has triggers, setting up a safe environment. I have a slide or two on seizure detection devices, which I think can be its own talk, but we're starting to learn more about them, but they have their pros and cons. Education and awareness, which I'm sure the foundation is doing a great job with. And then, of course, the supervision during sleep or somebody nearby, but you have to weigh the independence of what the patient wants as well. We have wearable seizure detection devices. There are bed and mattress seizure sensors. In the picture on the right there's these sensors can be, not typically EEG. I don't think that's really commercially available for people, but they're usually measuring some form of repetitive movement, muscle contraction, can be breathing, oxygen saturation, skin conductance, of course, heart rate. There are mobile apps now you can attach to like your Apple Watch or your other type of smartwatch. And then, there's just the old-fashioned pulse oximetry that can alarm people. Now, like I said, it's got to really be tailored for the individual patient. So it's something you really, if you're interested in, should really talk to your provider, because I think we have to establish what type of information we're trying to gather and what type of seizures these devices really can monitor. So they're really only good. So, I mean, the sensitivity is decent for tonic-clonic seizures, which does happen to be the most important seizure or modifiable risk factor. However, you can imagine if a sensor is monitoring heart rate and even movement, if I suddenly jump out of this chair or get out of bed or I'm walking downstairs, that they often have a lot of false positives. And if it's suddenly notifying a caregiver 3 or 4 times a day when that you're having a seizure, when you only have a seizure once every 2 months, it's one of the biggest reasons why patients don't continue to wear this device. Is it comfortable? It definitely probably doesn't look as sleek as the newest smartwatch. It's going to depend on when your seizures occur. There might be a stigma, battery life. Unfortunately, there is cost, and it's tough for insurance to cover these. That's a whole nother discussion. And some even have subscriptions now, like payment subscriptions, which I think that's just really prohibitive. And of course, the false alarm rate. So these are my last couple of slides. These are recommendations straight from the American Academy of Neurology. So basically telling clinicians, and I think the reverse can be true too. You can ask your clinician. I know it should be the clinician bringing it up, but like I said, it's really tough to find the time to bring this up. And now that you've been to this talk or you're here on behalf of somebody else, you have the power now to bring it up and learn more about this. But in children, a reminder that SUDEP does affect 1 in 4,500 children with epilepsy. And in adults, typically about 1 in 1,000. It's probably higher if you have drug-resistant epilepsy. And if you have tonic-clonic seizures, then really the clinician should continue to actively manage this, whether that's changing anti-seizure medications, maybe a genetic evaluation, genetics referral, just to try to figure out what type of epilepsy you have. Are you a candidate for some type of epilepsy surgery? I think just continue to remember that the tonic-clonic seizures are the highest associated with SUDEP. And then finally, I think this really is patient and family dependent, as permitted by psychosocial circumstances. But suggesting the use of some, whether nocturnal supervision, like sharing household or bedroom with somebody, or should you have some sort of listening device if you do co-inhabit a household with somebody? Is that hopefully not too much invasion of privacy, and what's the risk benefit? And this is it's a delicate conversation to have with the patient, the caregiver who's monitoring, and what type of independence they're looking for. Because at the end of the day, I struggle too. I want to protect people from SUDEP, but I also my goal is to have a patient who doesn't have seizures and is able to live independently and drive and have a job and be as independent as possible. So we're always constantly weighing that balance. Okay, these are really the main points. I think I went a little deep with the pathophysiology on this study, on this talk, but essentially SUDEP is a leading cause of epilepsy-related mortality. Risk factors include frequent tonic-clonic seizures, poor medication adherence, so missing medications, and then that induces poor seizure control. Nighttime seizures may be a soft risk factor. Prone sleeping position seems to happen a lot, but we don't know if that's exactly a risk factor. And then the exact mechanisms, there's likely respiratory dysfunction leading to cardiac dysfunction. But is there some kind of genetic component or some combination that we're not aware of yet? And then risk reduction strategies with your medical team, focus on optimizing seizure control and maybe the living situation if that can be optimized. And then finally, open communication. So just like I tell my colleagues to make sure we talk about the SUDEP with our patients, especially if they're having lots of seizures still. You should be empowered to ask about it and for your specific epilepsy as well. So I will stop there. This is our Dartmouth Epilepsy group at our last retreat, where we kind of discuss how we're gonna move forward, what are our goals for the next year, research, and those are my two little girls who just turned 3. So it's a fun ride I've been on. All right, I'll take any questions. Thank you for having me.
Thank you so much, Dr. Culler. We actually have quite a few. So
Okay.
I'm going to start with the first one that was asked. And then anybody else, if you wanted to unmute yourself, raise your hand, unmute yourself, you're more than welcome to ask the question directly to Dr. Culler as well. So I'll start with the first one. The first one I asked, I have a son who started focal onset seizures at 12. He is now going to be 50. On 4 meds, works 24 hours a week, been seizure free for 1 year. He snores. Should sleep apnea be a concern?
Oh, yes. So he's 50 or 15?
He's 50, 50.
50. Okay. All right. So that is, first of all, I have to say, so impressive that he's working on 4 anti-seizure medications. That's a lot of medications, a lot of brain fog potentially to work through. I mean, some people are just resistant to the side effects too. I'm very, very happy that whoever he's worked with has, kept trying, and that and he's seizure free for the past year. So the quick answer is there's data to support diagnosing and treating sleep apnea, if not just for better seizure control, because it's going to improve sleep quality, but also to modify risk factors in the future, like losing eyesight, hypertension, your stroke and cardiac risk factor, like having a heart attack. So if you think about it, if you're working so hard to breathe at night, not only are you getting poor sleep, but you're starving the brain of oxygen. You are just fighting so hard. And kind of, so the short answer, I don't have papers to back that up. The short answer is I would get him a sleep medicine physician, get him studied, get him on a CPAP. It's usually the most common way of treating sleep apnea.
Wonderful. Thank you. Our next question is, my son is 4, diagnosed this year with epilepsy. He continues to have seizures every few months, even on medication. Is this considered drug resistant, or is it possible to still have breakthrough seizures and consider the medication successful?
How many medications has he tried?
Ashley, you can unmute yourself if you'd like.
Yep. Yeah. So he's done just Keppra. So I don't know if it's just a function of the medication itself is not working and he's young and they're trying to figure out dosage, but typically the seizures do continue. Like his first one lasted over an hour, resuscitated in the ER. His next 3 were grand mal seizures where we went to the ER. He just had one a few weeks ago, which he was able to come out of, but that one probably still lasted about 15 minutes.
Oof. Yeah, so those are definitely severe seizures. If he's only tried 1 anti-seizure medications, it doesn't meet the definition for drug-resistant epilepsy. So typically, and it just really depends, some physicians like to give these medications some time, maximize them, and then try another one or add on another one. I think that seems like that needs to be the next step and potentially they're waiting for workup. I don't know what's been done so far, but in pediatrics, genetic testing is done a lot more. Is it a focal or generalized epilepsy? But certainly I think it sounds like the next step is to try another medication before saying this is drug resistant. And also in fairly young kids, there may be extended workup that's done beyond just the basic EG, MRI. I don't know where I'm going with this, but I think at least another medication needs to be tried. So potentially more expanded workup, because this could be an atypical epilepsy. If you're not at a big, well-known tertiary care center, so for example, that means Dartmouth, UVM, or Boston or something like that. I've told patients, I've told my family members, you should never be hesitant to get a second opinion too. I'm not saying that sounds like you need that here. If you have two people telling you the same thing, then everybody's happier. And I trust that your physician, the current one, would also be happy too. There's nothing wrong with getting a second opinion. Anytime I sense any hesitation with my own patients and their family, I can think of, easily a few people who I say, let's go see what somebody else has to say. But at least it's not ready to call this drug-resistant epilepsy yet.
Okay, thank you. And so they should, if the drug is successful, he should not have any breakthrough seizures. Is that accurate?
So the definition is disabling seizures. So
Okay.
it's really depend, something that's going to affect any of his daily life, like
Yeah.
school, learning, and not driving. So, in adults, because that's I don't actually see kids, but in adults, they are still allowed to have these kind of subjective auras. They might have a rising sensation or a little seizure warning sign, not usually considered disabling unless it happens 50 times a day and you can't get things done. But anything that impairs awareness, impairs learning, cognitive development in a kid I would consider disabling.
Thank you.
I have a question.
Sure.
Oh, okay. In regard to my husband, Mr. Torres. Thank you for your presentation here. Thank you, first off. But I had a question in regards to SUDEP. It is true that when you go see the doctors, a lot of them they don't really mention too much about SUDEP. But for our situation, we had a concern because my thing is as you get older, as you said, it could be SUDEP if you have epilepsy or something else like your heart or whatever. So you want to kind of keep track of both. You know what I mean? If you understand what I'm saying.
Sure.
But so in regards with my husband, he went in for like an EMU for a 10-day stay. And during that time, a bradycardia had been on his cardiac monitor. So that's when, because one of the questions is, how's his heart doing, stuff like that. And we were really starting to get concerned about SUDEP. So then after having that with the bradycardia, he had a Holter monitor and his heart checked, and he found out through a 48-hour monitor, he was having 10-second pauses in his heart. Long story short, his neurologist at the time and the cardiologist team, because we went to see another cardiologist, because one was talking about a pacemaker, but right now they're trying to change his medicine to see if that might be something. But anyways, with the bradycardia, after he had some more heart testing, it seems like it's okay, but I'm still you know what I mean? I'm still concerned about the risk of him having SUDEP, yeah.
No, that's a really good case. I can tell you, I mean, it's a really tough case, unique
Yeah.
case. We have patients who, and I think that's the thing, this is going to be this entity is rare, it's uncommon. We don't fully understand the mechanism, because a lot of people have primary cardiac issues or cardiac arrhythmias, and
Right.
the cardiologist manages it. So is this a primary cardiac thing, and they're saying he's fine, he doesn't need a pacemaker, or is this his heart issues are somewhat driven by his epilepsy and so I can give you a case where I had a patient who did end up getting a pacemaker, that every time he had a seizure, his heart stopped. But luckily it would come back after 20 seconds, and he would pass out during that time, the seizure would stop. And the cardiologist said, "Why don't you treat his seizures?" And I said, "Well, he wouldn't be here if we could treat his seizures. He's
Right.
here for like surgical monitoring, and so we should prevent his heart from stopping, and and I'll try to continue to treat his seizures." But we don't know, he's still doing very well. So you almost kind of tag team it in a way, and you can we looked up the data together, and everything is just a case report essentially, and it's not enough good evidence to know exactly what to do. So in your case, you know, it sounds like those heart issues are happening independent of seizures. So I would, it's somewhere in the middle there.
Well, with the bradycardia, because my understanding is a higher risk to have SUDEP would be bradycardia.
Right.
So he did have a bradycardia, but you know what I mean? But according to what the cardiology, they don't seem to be too worried about it, because
Right.
based on some other testing,
Yeah.
they didn't, you know what I mean? Like
Yeah,
right now,
right,
he's currently on a 2-week Holter monitor right now for cardio.
Okay, so he's still being worked up. I would,
Yeah.
you know, I would make sure that his neurologist and cardiologist are talking too, so that you're
Yes,
speaking the same
each other.
language.
Yeah.
That I've done that in the past. You can always suggest that, and at the end of the day, if you separate the two out, if he didn't have epilepsy, would the cardiologist treat this? I think that I'm not a cardiologist, but 10
Right,
seconds
right.
seems like a lot,
Yeah,
especially
yeah.
if he has any symptoms from it. So I would make I think you're doing a great job. Advocate for yourself, for your family, and honestly, if you're still not sure, I think a second opinion is might be a good one here as well.
Okay.
Thank
Well,
you,
thank you.
Orlando. And Orlando, we have, I had put a form in the chat. We have a host of people at EFNA that can help with a lot of these situations and kind of help navigate, like, should I get a second opinion and what are my options? So please, in the chat with our form is, please, you know, fill it out. We're happy to connect with you and definitely help with that. We have one more, Dr. Culler, to kind of
Sure,
kind of
yeah,
roundabout.
I've got time.
My daughter consistently has has a status epilepticus seizure every 2 years, despite never missing medications. They were always at night while asleep and last 1 hour to 5 hours before they stop. Obviously, she's hospitalized during that time. When we arrive at the hospital, her CO2 level is off the charts. Should we have some kind of oxygen tank at home to better control this, reduce the risk of SUDEP, and how would we obtain that?
Oh, this is a tough one. So one thing I didn't mention, or I might have briefly, so if someone has status epilepticus, that's like I mentioned, that's a very high, that's another major cause of epilepsy related mortality. But for other reasons, there's once the brain's seizing for that long, the medications required to stop that. I don't know if she was ever intubated or in the ICU. All of that's independently associated with morbidity and mortality, because the longer you're immobilized on those high dose medications, anything can really happen: cardiac, GI toxicity, clots. And so just if we're going to use terminology like SUDEP, it actually, having status epilepticus excludes you from getting the kind of SUDEP terminology, but it doesn't mean that the mortality is any lower. It's just that SUDEP is just like one seizure and then you have death. But what can you do at home? And the oxygen tank, you know. So what I'm hearing though is that once she has a seizure, it doesn't stop on its own. So oxygen's not going to stop that seizure. But I mean, could something happen with a prolonged seizure where your heart's, you know, just that's so much, it's so taxing on the heart or the breathing center? That is possible, but I don't see any way around where, and I'm guessing it's a clinical seizure, so that you know to bring her in or she's unresponsive. It sounds like you just have to bring her in. The one thing I would bring up is, that do you guys have a rescue medication? There are intranasal rescue medications now that are approved for seizures prolonged over 5 minutes. You probably do, and you're able to give that a couple of times. And if the seizure doesn't stop, I can't imagine any situation where you can have something at home where you can manage this on your own, just because the risk of a respiratory or cardiac failure is really high. So it's a really tough situation. In general, you know, and just to allude to some of the data I talked about where people retain CO2 and don't have a good response to CO2. So oxygen is kind of a little bit of a Band-Aid. It there's a brainstem arousal issue where patients just have really shallow, slow breathing, and their CO2 just climbs higher and higher. And that's, that's also toxic. So just pumping in a lot of oxygen actually doesn't fully control that. What we need to do is get patients breathing faster and get all that CO2 off. And so one of the things I've heard from kind of the researchers who are really in the front lines of this is that potentially in the future, and there's no one really doing this yet, what's needed is like a pacemaker of the heart, but for the lungs or for the diaphragm. So when someone has a seizure and they're not breathing really well, something is jump starting their breathing mechanism to get the exchange of oxygen and CO2. But do I have patients that I rarely have given O2? I would say the evidence is very low for doing that. It's kind of a dangerous situation when you start having like a hospital room in your own house. Uh, there are a couple of rare cases, but I think unfortunately there are pulse oxes and CO2 transcutaneous CO2 monitors that can alert you. So if that's another avenue of is she potentially having a seizure, and then I can get some help sooner, that could help. So something to talk to with your doctor. I hope that answered the question though.
Thank you so much, Dr. Culler. I also have one more question, and it's from actually my coworker, Amy Lopez. So Amy, if you want to read your question, go for it.
We had a SUDEP webinar before, and the doctor that presented mentioned as agitating the patient if their breathing doesn't seem normal after GTT. So I do have a son with Dravet syndrome. We co-sleep. We have monitors, but they don't always pick up seizures. So I'm right there with him. I can feel him getting stiff. He turns towards me. We do the rescue and all that. But as far as trying to prevent SUDEP, is that the best thing to do? Is like agitate them if they're breathing?
Yeah, in the moment, I'll be on. Yeah, that's the one bit I have not probably done a deep dive on, but I've heard of that many times. Yes. In the moment, it seems like it's not doing anything, but extra stimulation hopefully is bringing some things online quicker. Because what's happening in Dravet syndrome is actually the best studied in animal models. There's so many models. I kind of skipped over that slide. The divergent mechanisms, convergent pathways to SUDEP, and they really have this complete loss of drive to increasing CO2, and things go offline, where they don't wake up like they should after a seizure. I think any amount of stimulation, and that's really important. The fact that you're there if someone's face down and just flipping them over, if there's, a pool of saliva being on the side, actually is probably better to reduce the risk of aspiration pneumonia. All of that is very important. I can't say I've come across it. It's a hard thing to study because a lot of times there is SUDEP occurs alone and unwitnessed. And so you're a minority, but also it's a really important risk reduction to be in the same room as your son.
So that you're able to, like you said, make sure they stay on their side, they're not aspirating. You can stimulate them as many ways as possible. Okay. Thank you very much, Dr. Culler.
That's my understanding, yes.
Wonderful. Well, thank you so much, Dr. Culler. We're actually a little bit over for time, so we're sorry for keeping you.
Right.
And for everybody else for being here, we so appreciate it. Dr. Culler, thank you so much for joining Epilepsy Foundation New England tonight and for sharing your expertise on SUDEP. We're very, very lucky to have had you tonight, and love the pictures of your two girls. It's lovely to see the personal side of our doctors. And thank you for sharing that. I so appreciate it. Tonight's session has been recorded, so we will send that out tomorrow to all of you. Like I said, if you are here and a school nurse, before you leave, please put your email address and your name in the chat so that we can get you your contact hour. But thank you so much for everyone for being here tonight. And again, we'll be following up with this survey so that way you can also help rate tonight's webinar and then also talk to us about any future webinars that you may have suggestions for. So thank you again for tonight, and everybody have a lovely night.
Thank you again, Christine and
Thank you
Amy.
so much, Dr. Culler. Have a lovely night.
Bye-bye.